Hello, I'm Eamon Costello, CEO of patientMpower. patientMpower are experienced providers of remote monitoring solutions across a range of respiratory conditions and use cases. Our platforms enable the clinical-grade remote monitoring of spirometry data, oxygen saturation, and many more objective and patient-reported parameters. We know that COVID-19 means many of you are setting up remote monitoring platforms in your institutions for the first time. For this reason, we are pleased to bring you advice and best practice from respiratory specialists who have significant experience in remote monitoring of their patients and who have used patientMpower solutions. At the end of the webinar, we'll have time for Q&A with Charles, Daria, and Richard, and I would encourage you to use this opportunity to gain insights from their experience. We ourselves have extensive experience implementing remote monitoring solutions, helping institutions change models of care, and we are here available to provide support to you, so please don't hesitate to get in touch. I'm now pleased to introduce our first speaker, Professor Charles Powell, Chief of the Pulmonary Critical Care and Sleep Medicine Division in Mount Sinai.
Thanks very much, Eamon. It's a pleasure to be here and to speak with you all about our experience in implementing patient monitoring during the COVID crisis and beyond. I am the Chief of Pulmonary Critical Care and Sleep Medicine for the Mount Sinai Health System, and I will be speaking to you about the context for which we decided to implement a patient monitoring approach as we were confronting the COVID crisis. So there are many steps that all institutions have gone through to confront the COVID crisis. The crisis involved making sure that all institutions are able to manage the volume of patients who required services in the ambulatory and the inpatient environment. In the inpatient environment, much attention was placed towards ensuring that there was sufficient equipment, sufficient beds, sufficient personnel to manage all the patients who required our services and the services of our colleagues who have confronted this crisis in the United States and beyond. We've also now been confronting a unique disease in terms of the ARDS that is induced by COVID-19, and we are managing the sequelae of patients who have survived ARDS due to COVID-19. That is really part of this new normal in which we are adapting to the virus in our communities, and we are able now to be able to manage patients who have the sequelae of COVID-19, and that is the focus of our efforts to implement this patient monitoring approach. I want to set the stage a little bit, if I could, in terms of what I mean by the crisis that we are talking about. We, of course, are located in New York City, an epicenter for COVID-19 in the world. As of June 16th, there were 207,000 cases of COVID-19 in New York City alone. 54,000 hospitalizations have occurred, and 22,000 deaths. The Mount Sinai Health System represents about 17% of the market share in this area. We have 8 hospitals in multiple boroughs, including in Long Island, New York City. We annually see 4.1 million patients. We have 410 ambulatory practices, and of course, we are affiliated with the Icahn School of Medicine at Mount Sinai. This is the timeline for COVID-19 as it pertains to our experience and the experience of others. This all began in December in Wuhan, in China. It came to the United States starting in the state of Washington, as we all know, in February, and made its way to New York at the end of February, and our first admission to New York Mount Sinai Hospital System was on March 7. Shortly after that time, there was a steady and significant surge in the number of patients admitted to our hospital over time. There was also a concomitant surge in the number of patients who were discharged over time, such that we've had over 6,000 discharges from our health system as we have been managing this crisis. So we are now at the tail end of this initial surge of the virus, and this diagram on the left shows you the total number of patients who've been hospitalized in our system during the COVID crisis. We peaked on April 8th with 2,200 patients in our healthcare system, just shy of our usual bed capacity of 2,500, and well shy of the number of beds that we were able to create to accommodate the surge that got us to a capacity of 4,200 beds. What you can see now, though, is that the number of patients hospitalized is much lower. The patients who remain in the hospital now are typically those who have long-term sequelae such that they are unable to be discharged at present. They have chronic respiratory failure or other conditions that prohibit them from being discharged at this point in time. The number of new admissions is very low. On the right-hand side, you can see the admissions really have gone down to a trickle, only a few every day in the Mount Sinai Health System in New York. And that is representative of the experience in New York, where we've had a very aggressive program for social distancing that has been quite effective in reducing the number of cases and preventing new cases over the last several weeks. We are pulmonologists, and we, of course, have been intensely focused on treating and understanding the COVID-19 ARDS. It, of course, is a form of acute lung injury and is associated with a high incidence of respiratory failure and mortality. And what we and others have learned is that this is not the typical ARDS that we had seen associated with other viral diseases in the past. There were several characteristics of this that were unique. Specifically, the physiology was different. The lungs tended to be much more compliant than we were used to. There was quite a bit of evidence suggesting the importance of shunt physiology and also the importance of the prevalence of microthrombi and large vessel thrombus that would account for hypoxemia and respiratory failure. The treatment approaches have been quite varied, and they were implemented quite quickly, starting with clinical trials and now resulting in accepted therapies. We and multiple institutions have used therapies that have included remdesivir, IL-6 blockade approaches, convalescent plasma, mesenchymal stem cell transfusions, as well as clinical trials looking at inhibitors of GM-CSF and complement using drugs such as eculizumab. We and others also determined that there was a benefit of using anticoagulation in a large number of patients who had elevated D-dimers or other risks for clot, and we also determined there was benefit in using corticosteroids in selected patients. But what we're really focused on dealing with now are patients such as those who have a CT scan that I'm showing on the right. This is a CT scan of a survivor of COVID ARDS. This patient presented with respiratory failure, did not require mechanical ventilation, was able to be supported with high-flow nasal cannula successfully, received remdesivir, received convalescent plasma, and was able to be discharged to home without requiring supplemental oxygen. But this is a dual energy contrast CT scan that we performed 6 weeks after his discharge from the hospital. And what you can see is that there is extensive airspace disease, predominantly ground glass opacities that are diffuse in both lungs without evidence of fibrosis at this point in time and without evidence of clot. This is a typical image of a typical patient who we are now seeing in high volume in our Respiratory Institute locations. We have 2 Respiratory Institute locations in Manhattan, one in the Upper East Side where I am located presently at Mount Sinai Hospital, and then we also have one downtown in Union Square. We see approximately 37,000 patients visits per year, with a large proportion of these patients now being those who have survived COVID. Many of the patients who we see have survived COVID had an initial hospital stay, but not all have. And what I want to just show you now is the context in which we have managed patients who have been in the hospital, have survived COVID, and now require care for their respiratory disease. Our program, in terms of using the patientMpower platform for monitoring patients at home, is part of a large-scale effort to manage patients being discharged from the Mount Sinai Health System. There's a transition of care program, which is a high-touch program that is implemented for all patients who are discharged from COVID-19 related illness. So all patients after discharge are contacted at least twice by phone for follow-up, and then also are enrolled in a text-to-chat platform so we can maintain contact with those patients during the crucial first several weeks after discharge from the hospital. We overlaid on top of that the patientMpower monitoring program for patients who had had significant respiratory disease during their hospitalization. So we overlaid on top of the transition of care program the patientMpower monitoring program, which was directed towards patients who had respiratory failure during their time in the hospital. These are patients who required mechanical ventilation, high-flow nasal cannula, non-invasive positive pressure ventilation as examples, and who were able to be discharged to home, either on supplemental oxygen or not on supplemental oxygen. So these patients then were presented with an oximeter, were linked to the phone application, and then were monitored by the Respiratory Institute staff after discharge. So this is what it looks like. Patients were provided with a Bluetooth-enabled oximeter, which linked seamlessly to their phone. It works in an Android or the iPhone application, and that was fine for most of our patients who were in our health system. Patients typically were instructed to check in to the application with their device at least twice per day, and we monitored their entries as they came in to the Respiratory Institute monitoring team. So I'd like now to discuss the challenges and the opportunities that we have identified as we have developed and implemented this patientMpower monitoring program for our patients with COVID-19. First, the monitoring program provides an added expense to us. But we find that the expenses for the oximeter and the monitoring program are covered by the reimbursement codes provided by Medicare and by other payers. The codes here are listed for you here on the right-hand side. The second issue is patient compliance. We have had past experience using digital health tools, specifically for patients with asthma and with COPD. And we, like others, have found that patient compliance is variable. What we've noticed is that in this situation, patients who have COVID-related disease are quite motivated. And so the compliance rate is higher than what we've noted before with other diseases that we have used digital health tools. Secondly, the compliance is enhanced by the nice user interface provided through either the iPhone or the Android phone. Next, we introduced a new workflow into our ambulatory practice, a workflow that requires our staff to now monitor patients who enter data and also to be in contact with clinicians so that action can be taken if there is an abnormal finding or if a patient seeks out help. And therefore, we have to have the ability to engineer quick appointments for patients who need to be seen. And we've been able to do that with our existing staff. And as we ramp up, additional staff will be hired. Again, this will be supported by the reimbursements that will be coming forward from the charges that are now available for this service. Next this is a new technology. Some people are quick adopters, some people are slower adopters. We're encouraging quick adoption of this type of platform. We see the benefits of being able to have continuous contact with patients with respiratory disease. Respiratory disease is a chronic process. It goes on before and after the patient leaves our offices. And so having the ability to be in continuous contact with the patients, both in terms of their symptoms and in terms of their physiology, we think is important value added. And if we're going to talk about patient-centered care, I think it's important to understand and appreciate that now with this type of approach, we're bringing the care to the patient. instead of relying upon the patient coming to us. Finally, there's quite a bit of important data that flows from these devices into the system. It's important to be able to capture this data, analyze this data for predictive analytic purposes, and also to ensure that we are learning the most we can learn about each specific patient and learning the most that we can learn about this specific condition. This is facilitated by having a user interface that is easy for us to work with, and the dashboard for this platform is easy for us to work with. And the data analytics are facilitated by having the ability to connect to our EHR system, which then allows us to look at the data using the data sciences team at Mount Sinai, which has significant expertise in managing large quantities of data and making clinically important observations that will drive better care in the future for patients in COVID and also for patients who have respiratory diseases other than COVID, which is our future direction. Well, thank you for your attention.
Thanks, Charles. So next, I'm pleased to introduce our next speaker, Professor Daria Rudium, who's a lung transplant pulmonologist at NYU Langone.
Thank you so much, Eamon. Thank you for inviting me and for the introduction. So what I hope to walk you through over the next session is our experience here at New York University in establishing a home monitoring program way before COVID and how that involved for our lung transplant recipients as we saw our program and COVID take over the last few months. So to give you a little bit of background, the number of lung transplants in New York has increased over the last few years. So prior to 2017, there was really just one lung transplant program in New York City. And over the last few years, two others have established themselves, ourselves pictured here in purple, and then another center in light gray, and then the pre-existing program, which is New York Presbyterian Columbia in dark gray. So we're a fairly young program on the map of New York City. And from the get-go, we really envisioned that we would like to have some sort of home monitoring in place for all of our transplant recipients. Why? Well, it was really for the benefit of having both increased patient and provider assurance. What I'll say there is that actually came from the other program in the city from NYP in Columbia, where we didn't have as much of a robust home monitoring. And as a provider now in my institution, NYU, it offers me a lot of comfort to know that patients, when they go home after having received a lung transplant, have a set number of parameters that are being monitored on a daily basis and remotely. So it just offers a lot more reassurance that the patients are doing okay. And for the most part, our patients tend to agree that they see a lot of benefit in having home monitoring in place as well. Our second major advantage of starting home monitoring for patients was really just to expand the geographic pool. So all three of these programs that you're seeing here in New York are New York City centered, and New York State is a really large state. There are many neighboring states as well, and a lot of patients who do need transplants. So what this allowed us to do is to expand our potential candidates to all the way upstate New York, north of Albany. So these are folks who are 4 or 5 hours away from New York City, and we were able to offer them this intervention, knowing that we would have a robust monitoring in place after they receive a transplant, so that appropriate routine care is being provided for these folks who are farther away geographically. So what does it actually look like for patients? So on that index hospitalization, the hospitalization during which a patient receives a lung transplant, upon discharge, we sit down with them and we equip them with the following devices. So there are a number of different things that essentially look at their vitals. So we're looking at their blood pressures, heart rates. They do get a thermometer. Obviously, lung transplant recipients are immunosuppressed, so they're very much at an increased risk for infection. So temperature is one of the vital things that we'll be checking for them. They do get a pulse oximeter. They get a scale and glucometer, and actually a pedometer as well. Those things are crucial, as a lot of these folks go home on higher doses of steroids. They end up gaining weight. Their glucose is not well controlled. So those things we monitor very closely as well. And then my kind of absolute favorite and really the holy grail of the whole thing is the clinical grace parameter. So for those of us who don't do lung transplant on a daily basis, one of the most common and most feared complications of lung transplant is rejection. And it happens to a lot of folks. It happens to the majority of folks, and most of the time it is asymptomatic. So the only ways to pick up a rejection in a lung transplant recipient is either to do a bronchoscopy with a biopsy or to see an FEV1 decline. Now imagine if you have a patient who is seen, say, every 2 months, and in the 2 months in between that they're not being seen by a provider, they could be having an FEV1 decline that we otherwise would not know about. So having this handheld spirometer in place with which they go home, at least for us, has been an incredible amount of reassurance and comfort knowing that we are on a daily basis monitoring the FEV1. All of this gets linked through Bluetooth or cellular data to a healthcare app, and then gets auto-populated into our electronic medical record. So we use Epic as our electronic medical record, and this is what my screen would look like if I were to log in and review a patient. So on the left side, you see just a day kind of screenshot of what that person's values are like for that day: their blood pressure, steps, heart rate, oxygen saturation, temperature, and FEV1. I would say that on the vital signs alone, we have picked up a number of different things. So there are definitely a few blood pressures that were a little bit on the lower side that we were able to pick up and intervene upon, and actually a fair amount of heart rates that we thought were a little overly beta blocked, or we actually picked up a case of myxedema in somebody who had a really low heart rate at home who was completely asymptomatic. Turned out to be a drug-drug interaction from transplant meds. But my favorite attribute of this home monitoring is this. So this is what the FEV1 looks like for any of our patients when they do home monitoring on a daily basis. So this is a trend that you can see here on the top over the 6 or rather 8 months of a person's transplant life. So you can see that after transplantation, they had an FEV1 in mid or low to mid 4s. And as the time has gone on, the FEV1 decreased. So this is rejection. If you look particularly between November and December, so over a course of months, from 1 month, from November 2nd until December 8th, there's rather precipitous decline in FEV1. If we did not have this person on our radar, or if we did not have home monitoring in place, we would just have no idea. A lot of the times, folks don't feel this type of FEV1 decline. Some do, but not all. So this was really instrumental in helping us detect rejection, early rejection in a lot of these folks. This particular person was brought in, they underwent bronchoscopy with biopsy, we were able to diagnose rejection and intervene with steroids. So the benefit was definitely there way before COVID, and everything I'm saying right now is really all before COVID. So we were very, very fortunate to implement a system really where we started to do home monitoring along with some video visits before any of this unraveled. So pre-COVID, we did about 3 to 7 video visits per week, and these visits were mostly for the folks who live farther away, so in Albany or far in Long Island. We do actually have a few patients who live in Carolinas. There's one patient that lives in Florida, so folks have really traveled a little bit farther away, and we were able to monitor them appropriately with video visits and home monitoring. We looked into this in the very beginning, and one thing I haven't mentioned yet is in general, and this is center-to-center dependent, the typical follow-up for a lung transplant recipient is a weekly clinic visit for the first 3 months. That's obviously very time-consuming. It's costly. Driving into New York City, you're paying for gas, you're searching for parking. There's a lot of different variables in there. So to take that away and have a essentially remote monitoring where we're seeing somebody by video offered a lot of comfort to a lot of people. So I started doing that for folks who live far away. And we looked into this rather early and saw in about 2/3 reduction in our outpatient visits. So we were able to minimize the amount of physical face-to-face interaction, but still provide adequate care. This was, of course, because the home monitoring was done on daily basis by the patients, and our review of the home monitoring was done on a weekly basis. Patients were then called if we detected anything. We do set certain parameters, kind of alarms of values that fall outside of what we expect to be the norm. And of course, we intervened early on anything that popped up as abnormal. So all of this was before COVID-19. And so when COVID hit, and COVID hit hard, as Dr. Powell had already mentioned in his presentation, we were incredibly lucky to have had this system in place for our transplant recipients. Basically, on March 23rd, as it was really the first week that things were being felt very heavily in New York City, we were able to convert all of our patients to telemedicine in conjunction with home monitoring. So not a single person was seen in person unless they had to be admitted or undergo a procedure for 2.5 months. We asked our patients to do home monitoring twice daily. We were, of course, concerned about the well-being of our patients and what COVID would mean for a lung transplant recipient. And over the course of the last 2.5 months, we have done well over 250 virtual visits and twice daily home monitoring with our devices. So what has panned out of that is we've been able to maintain routine transplant care despite being on quarantine and lockdown and social distance with a lot of restrictions that we previously have never had exposure to. And the additional benefit, which we're very glad about, we were able to pick up 2 asymptomatic cases of COVID-19 in our transplant recipients, and we picked them up early because we had the home monitoring, had them take temperatures at home and call in. And so both of those folks got appropriate care, early care, and made it out very well. So all in all, having had this system in place was just something that we were incredibly lucky to have. So now moving forward, what we have seen over the last week and a half, we have opened our physical clinic on really kind of case-by-case basis to determine who would need to come in. And this is mostly just physical exam folks who really want to make sure we're seen in person. But over 90% of our visits remain virtual visits, and we continue twice a day home monitoring. And so far, it's working very, very well. So we intend to proceed this way for probably very, very long time. The first wave of COVID seems to be at its tail end, but nobody really knows what's going to happen and how much further this will take us and the rest of the country, so in the world. So we're really hoping to continue this kind of practice. And again, we had no idea that this was coming, and we're so lucky to have had a telehealth and a home monitoring system well-oiled before COVID had hit. And so we're learning, and we'll hopefully continue to learn and experience through all of this. And we wish for everyone to have some sort of systems in place when disasters strike, and hopefully we'll make it out okay on the other side.
Thanks very much, Daria. I'd like now to introduce our final speaker, Professor Richard Costello, who's a respiratory physician at Beaumont Hospital in Dublin in Ireland. He specialises in asthma and COPD and was involved in the national coordination in Ireland's COVID-19 response.
Good afternoon, or hello everybody, and thanks for taking the time. I'm sure, like you, I've really enjoyed the previous 2 speakers sharing their experience with technology and how it has a practical value in healthcare. And I'm just going to take that conversation just a little bit further. And we heard quite a bit from our colleagues about the value that they got very quickly from starting to bring in remote monitoring technologies into their practice. And you could see the clear value. They were able to longitudinally collect data on their patients. That data was objective, which is really useful. But I think most importantly, and Daria really made that point so clearly, that it was at home. You could really see that little extra spice of having information collected in the patient's own home. Where I think the real value at the next stage starts to come, and Charles alluded to this in his talk, was what happens when you get data scientists involved and you start to look at combining the data from multiple sources. And that's where the real power of this type of digital, remote, handheld technology starts to come together. And I'm going to illustrate just with a couple of features how it has diagnostic value, how it has predictive value, something that clinicians, despite their apparent crystal ball, don't really have. And I think most importantly, and we've already seen it to some extent illustrated from the 2 talks, how adaptive this type of technology is to novel situations. Let me explain in briefly. This is a sort of a solution architecture picture. So if you take data, say, on lung function measurement, and then you combine that with treatment use and perhaps some patient input on their symptomatology into a portal like we've just seen described, and then you run data analysis of this data that's curated in a database, you can then start to see the cause and effect of what treatment is having on lung function and vice versa as over time on the same individual patient. And then you can use that data then to have a sort of a communication that the patient can see these interactions, and also at a more macro scale, like we saw earlier, that the patients themselves can see the data, but also the clinical team can see it at either at an individual level or at a group level. And that becomes very powerful. And let me show you exactly what I mean. This, for example, is the lung function measurement on a patient with asthma. The peak flow is shown here. It's recorded twice daily by a patient. The green is the morning time and the evening is in blue. And just to look along here on this axis, you can see the months going by. So through quite a number of months, through an 8-month period, you can see that this individual's lung function has really done very well. It actually improves quite considerably during the summer period. And then there's a precipitous decline with an exacerbation illustrated here by that red spot where they took a course of oral corticosteroids. What you can see at the same time then is the measurement of their twice daily long-acting beta-agonist inhaled corticosteroid. And in the brown, it may not traject terribly well, is their reliever use. So what you really can see in a very short snap overview is the clinical longitudinal course of the patient with asthma. And you can see, I guess, in this case in particular, that their exacerbation was, in this case, in the autumn, and it wasn't related to poor adherence. So most likely, you'd need to make a treatment change for this individual. So let's go through this diagnostic in a little bit more detail. This is this is the lung function, again showing the peak flow and time over several months here of an individual who started with this. They were symptomatic. They were having a lot of exacerbations. We thought we should really plug them into this remote monitoring severe asthma program. Their lung function, you can see, really was subadequate. The red is shown here to illustrate that it was less than 80% of what we would have liked. You can see these marked variations in morning time, evening peak flow, which are a classic characteristic of asthma. Something that, back in the day, everybody with the background knowledge of physiology who did a lot of peak flow monitoring would have been well familiar with. We've become less familiar with this as we do point-in-time testing with spirometry. But what's kind of interesting to look at is the coexisting LABA ICS use. So the LABA ICS use is shown here, and on the y-axis you can see the time of the day, and then the time is along the x-axis. We can see the green illustrates that the device has been used correctly. This is a bespoke monitoring device that my research team developed, and what it allows you to do is to understand if the inhaler was taken correctly, in which case it's illustrated in green, or orange if it's taken incorrectly. So whilst this individual is really adherent, particularly in the morning time, perhaps less so in the evening, you can see there's an awful lot of ineffectively taken treatment, which probably explains why the lung function dropped. They weren't so good in the evening. They really were taking it erroneously in the morning, so the peak flow was dropping. So this individual is going to tell you in clinic, I've been taking my treatment, doc, I've been trying my best. And they have. It's just that they were inadvertently making an error. Now, we stage a number of visits where there's feedback given to the patient. So as soon as we recognize this error and did an intervention, you can see that the error disappears. They are starting to be more adherent both in the evening time and the error is going. And the lung function gradually improves. And that's a feature of asthma that we've also caught on to, which is that there's a lag between improving your technique or taking your treatment and actual stabilization of your asthma. Everybody's familiar with this, but the rate at which you improve is actually quite personalized. And that's really important because you can see now this individual is stabilized, but the corollary is true. If they were to slip in their adherence, we wouldn't see a decline in lung function until some period of time later. And just going along with that clinical improvement in their peak flow, this is the beta agonist or the albuterol use. You can see there's a horrendous, a huge amount of albuterol use in the beginning period. And that's probably why the lung function is relatively good up here. So you can see the value of having these multiples of interactions. And then as their airway condition stabilizes, you can see there was a bit of a cluster when it really dropped low. And then as they get better, their reliever use falls away. So you can see this value of the interactions of the multiple data sources. This is another interesting case. This is a patient who, again, on this axis you can see time, and this is months. So you can see that this individual is really tremendously diligent about taking their treatment, punctually and on time, which is excellent. And this is their lung function, which is really very stable. There's some high readings, but basically this is very stable. The value here is running about 500, but they remained profoundly symptomatic. Their asthma control. So if you used their symptoms and saw them periodically in the clinic, you'd be very worried because their ACT, their asthma control test, indicated that it's very profoundly suboptimal care. And the reason for that, it turned out, was that by knowing that we got a person who had normal lung function, had been taking their treatment but was symptomatic, that we could attribute their persisting symptoms to an elevated BMI. And that's something that says that we've really got to be careful about symptom as the only way that we can assess asthma control. These data points are also valued predictively. I explained that it takes a little while for a lab ICS to be effective. So a periodic drop-off in adherence may lead to an exacerbation, but you need to know what the person's threshold is. So we've developed, again, by a data science process, a personalized threshold model, a bit like a vancomycin level or something like that. And so if you serially measure the lung function or the treatment use, and you serially measure the lung function, and you have a personalized threshold that the individual works off, you can see, as shown here, their treatment use is staying above threshold. There's a few declines here. They stabilize, but here they drop to well below their threshold, and an exacerbation occurs. So the reason for this is that this would be the time to intervene. If your dashboard illustrated that the threshold had been breached and they were sub-threshold for a period of time, this would be the time for a nurse practitioner or one of your colleagues or yourself to call and say, listen, you're below threshold, you're liable to run into an event if you don't start to use your treatment a little bit more regularly. Finally, I said they're adaptive, and we've talked about COVID, and just to illustrate how adaptive digital technology is, we developed a score when COVID came in. We read from the Chinese literature that there were a number of premorbid risk factors that were responsible, like obesity and hypertension. But we also realized that that was only good for telling you that somebody was going to run into trouble, but not when. And obviously, as Charles indicated, it was a lot of ARDS. So we developed a score of respiratory distress involving not just how much oxygen they were getting, but what the SATs were like and how much non-invasive ventilatory support they were getting. And we called this the CCI score. And when we layered that risk factor on top of their baseline risk, we could plot over time. So we developed this app that our house staff used, and that we could plot every couple of hours what the CCI score and the individuals were. So here you can see somebody who starts with quite a high risk score, but over time, they spontaneously recover. This individual, on the other hand, didn't do so well. And the real value to this was we were able to predict 12 hours or 24 hours before that they were going to need an ICU bed. And I could do my ward round starting with the patients in the red zone and then the orange and then the green, rather than starting my conventional ward round, on a particular ward. And this allowed me to concentrate. I could do the handover on these patients and so on and so forth. This illustrates the value to this type of digital technology. And our score and baseline score were very predictive of ICU use. So to summarize, I think digital technologies are able to improve clinical care. We've heard Daria, we've heard Charles talking about their own personal experience in the remote COVID clinic, in keeping folks with transplantation safe and well and away from trouble, and delivering really preemptive and adaptive care. And I'll illustrate that you can do this in multiple other diseases. I've illustrated the diagnostic value in asthma. its predictive value analysis, something that we really have not had before. And together, depending on the situation, depending on the patient's own needs, we can make these systems adaptive. So I think there's a huge, huge potential for these technologies going forward. Thank you for your time.
Thanks, Richard. So before we go to a Q&A with our panelists, I'd like just to spend a couple of minutes just talking a little bit about our experience and some of our deployments. So patientMpower is a specialist provider of remote monitoring and respiratory disease, and we're fortunate to be working with leading health systems in the US, Ireland, and the UK. And we're delighted to be working with some of the leading academic medical hospitals around the world, many of whom have supported our early clinical validation studies into the use of home monitoring technology. With the evolving pandemic earlier this year, we analyzed how our existing respiratory remote monitoring platform could be adapted for COVID-19. We designed and built a solution focused on clinical grade oxygen saturation monitoring, connected via Bluetooth oximeter, as Charles mentioned. We won a contract with the Irish Health System, and between March and May, over 1,000 Irish patients have been cared for at home using this technology. And this provided significant capacity relief to the Irish Health System. There was two primary use cases. Firstly, for early discharge for patients who continue to need remote monitoring, similar to the use case that Charles outlined. Secondly, where patients had symptoms but did not meet admission criteria, they could be monitored from home and admitted to the hospital when their saturation deteriorated to a threshold that could be defined. Our solution is used in a wide range of clinical use cases. So our earliest work was in interstitial lung disease, and 2 years ago we won the IPS Catalyst Challenge, which was focused on remote monitoring technologies for idiopathic pulmonary fibrosis. In cystic fibrosis, we are working in both adult and pediatric care, and we're increasingly working in asthma and COPD care also. Due to COVID-19, we're now also working with pulmonary rehab centers in allowing them to virtually run their classes so they can understand saturation and breathlessness for attendees of their classes. And we're also helping clinicians assess oxygen needs remotely. Our solutions collect objective data from a suite of connected devices, such as spirometry, oximetry, blood pressure, weight, and temperature. We also facilitate collection of other important data, such as blood glucose data in lung transplant. We collect subjective data, such as patient-reported outcomes, and also breathlessness, such as the MMRC and the Borg scale for pulmonary rehab. We also connect to physical activity trackers, which can just track the step count by carrying your Apple or Android phone, and also Fitbit activity trackers. And we also allow patients to get alerts on local air quality, warning them when it is poor. And we had 2 poster abstracts at last year's ATS in Dallas on this. As mentioned, our COVID-19 solution focuses on oxygen saturation monitoring, temperature, and also symptoms, which are important for monitoring these patients remotely. All of the data is collected in real time and presented on a clinical dashboard and can also be integrated into the electronic medical record system. We also help define alerts, which can alert both the clinicians and the patients and their caregivers if their condition deteriorates. And this was vital for COVID-19 patients where their oxygen saturation could be declining rapidly. As Charles mentioned, there is reimbursement in the US from CMS and other payers. But what we're also finding is health systems in other countries are now willing to invest in remote monitoring technologies to help provide continuity of care for patients in the COVID era. Thank you for your time, and I'd now like to invite your questions from our panelists.
Now time for the question and answer session of today's program. You may submit questions by typing your question into the Q&A box on the right-hand side of your screen and hitting enter. First question, do you have race or ethnicity data, outcomes based on race? Anybody want to respond to that one?
Charles, do you have anything?
Oh, go ahead.
Go ahead, Daria.
No, I was just going to say that we don't have full data. We haven't analyzed that. But what I'll say anecdotally is that we have seen a few folks who, it's more of a socioeconomic reflection than anything else, If you folks who have lower amount of years of education, and they tend to be of Hispanic race or a couple of Black folks, it's just harder to get the same kind of literacy with using home monitoring, and the compliance tends to be a little bit lower. This is not full supported data. We've had 77 transplants who've done this, so there's not much power to this research. But in terms of, I saw your question pop up a couple of times. It is something that I think is worth mentioning, as this just tends to kind of represent a different, potentially different patient population that's just not as equipped to handle this kind of equipment.
And this, Charles, I would just add that this is under intense scrutiny by our institution, every other institution as well, to try and make sure these types of technologies can be made widely available. Many of our patients don't have an iPhone, can't afford an iPhone. Many of our patients don't have access to Wi-Fi. There are other remote monitoring platforms that can bypass those bottlenecks that occur with this platform. But for this platform, we are looking at race, at ethnicity, and we'll report out as we gather the data.
All right, next question. How was the ability to manage the app device assessed? Was training given? Do you have demographic data on who received or participated in the program?
I can address this one as well. So for us, at least for transplant recipients, it's different than the rest of the world, but we do sit down with them for at least an hour, and this is with a primary caretaker at home, usually a family member. We troubleshoot a lot of different things. So there's very, very dedicated training that's taken very seriously, and every single person who gets sent home with these devices gets that training. And our success is really dependent on how much of support they have at home.
Yeah, so
Can you please go ahead,
Charles, and I'll add on. We unfortunately are not able to spend an hour with each patient. So we do this at the time of discharge. So a member of our team will go to the bedside where the patient will be there, typically with a caregiver, and we'll do a orientation to the program, provide the device, make sure the device links up to the application. And then we rely upon the support services provided by patientMpower, which we have found to be very helpful. So if the patient does have any problems in following the video, in connecting, then they reach out to the support line. We find that there's very good uptake, but we do have some gaps. It probably would be less if we had the type of support initially that what Daria is talking about, which sounds terrific.
All right, next question. Can you please address the dynamics of changes in workflow and how staff reacted to additional efforts required for the program to be effective?
Well, this is a big change for us since before COVID, we did very little telehealth, very little telemedicine, and now we do a lot of both. And now on top of that, we introduced this type of digital patient monitoring platform. So it's a lot of things changing at the same time. Different personnel have different acceptances of change. We really portray this not really as adding work, but really substituting some work for other types of work. We started off on a pilot basis where we repurposed some of our staff to take this on as an added responsibility, but as we scale up, we will need to hire additional FTEs to take on the additional workload, which will be substantial. And so that's how we've been looking at it, and that's how we've been able to engage our staff and find acceptance at this point in time.
Next question for staff capacity. Did you see an acceptable HCP to patient ratio that was adequate for monitoring patients?
So yes, especially early on, it's not that much additional workflow at all. It really, the more you do it, the more you really appreciate the benefit of it. It's not more work. In fact, subsequently, it may save work, because instead of waiting for patients to call 2 or 3 weeks when they're extremists, you get a clue that something's wrong right off the bat, and you can intervene relatively early. We've had some real interesting anecdotal cases that demonstrate that benefit. Right after discharge, a patient transmits a reading where there's hypoxemia. We would not have known without the digital monitoring. So what happened? What happened was that the instructions really weren't received in terms of how to connect the oxygen to the patient when they went home. So that was a relatively easy fix by our team by connecting with our DME provider, who in turn contacted the patient, who in turn then was able to connect to oxygen, and therefore that was a little bit of work on our part, but saved a lot of work that would have occurred if the patient had persistent significant hypoxemia for a longer period of time.
What platform do you recommend for telemonitoring patients that use mechanical ventilation?
No experience with that.
So that's a different type of platform than what we're talking about here in the ambulatory environment. There are several vendors that supply platforms that integrate monitoring from in-hospital systems. That's outside the scope, I think, of what we were covering today. Be a great webinar for the future, perhaps.
All right, next question. What are essential features of clinical grade spirometry for remote monitoring?
So it's a handheld spirometer. As we saw, Eamon had in one of his slides, so did I. It's a small orange spirometer, and it basically tells the patient to blow for 6 seconds. You get an FEV1, FVC, you get a ratio of PAF, and that's really kind of the minimum that you're receiving. At least for us in the lung transplant world, we're very hyper-focused on FEV1, and that's really been incredibly helpful for us.
Next, what is considered a significant decline in FEV1?
I think that depends which etiology you're referring to. Again, for transplants, we make note of it if it's anything equal or greater than 10% from a baseline that patient establishes after receiving a transplant.
Is the home spirometry reimbursement available for only transplant patients?
No, that would be wider than so. Yeah, the CMS codes are for in the US are for remote monitoring of physiological data, so it's not specifically tied to transplant patients.
And for lung transplants with home spiro, how frequently do you have patients do the home spiro? Daily, a few times a week, weekly?
Daily.
All right, this next question for you, Daria. First of all, thanks for sharing the data. Approximately how much would it cost to implement such a program with pulse oximeter and spirometer at the hospital?
I think that's a better question for Eamon. I do know that now with reimbursement, it's a lot more manageable for us to actually implement that. We have been paying for equipment going forward. But the actual number, I actually truly don't know, so that might be a better question for Eamon.
Yeah, so from a reimbursement landscape in the U.S., you know, the fees for implementing this are less than what the reimbursement potential is. So, you know, and obviously there's kind of staff costs associated with doing the monitoring, as kind of Charles was outlining. So feel free to get in touch with us on that, and we can kind of see what it would cost for your institution.
Our next question, did NYU do the remote monitoring in other pulmonary groups such as ILD?
That's a great question. It has definitely picked up a lot of attention and has been entertained by a number of our groups, ILD, bronchiectasis, a few others. They're sort of in the process of rolling out some form of this, and I think this is really fired up by COVID and the idea of home monitoring. I don't believe we have quite as robust system in other pulmonary practices quite yet, but there's certainly interest.
I know, Richard, in your institution, there's been a range of different pulmonary areas you've been monitoring in.
Yeah, we've been monitoring long-term in asthma, in folks with COPD following admission to see if we can avoid readmission, and in pulmonary fibrosis. There's a move towards cystic fibrosis. I see no reason why pretty much any airway-related disease shouldn't be monitored in this way. I mean, everybody's making the comment that you can predict or you can detect events, and the longer we go with each individual disease, the more likely we are to pick up additional signals before people crash and have to come to the emergency department.
All right, we've got somebody who wants to know what software provided this data.
I think they're talking about Richard's presentation.
Yeah, that's proprietary research data at this stage. It's something that we're looking to try and roll out, but at this stage it's a research platform.
Okay, how is the PEF measured at home?
I think that was our work, and that's a digital system just like the one that Eamon has outlined and the guys in New York have explained.
Another question, have you compared different brands of home spirometers? Are some better suited to capturing FEV1 versus FVC data?
So we ourselves analyze a range of different spirometers. So the one that we work at is from a well-established maker of spirometers. It's fully embedded within the patientMpower application, and that's very much with a view to providing a good user experience for the patient, so as they have a single interface for doing their spirometry, their oximetry, and other measures. So it captures, as Daria mentioned, FEV1, FVC. We are also currently implementing that you'll be able to see the expiratory flow loop. Because much more demands on being able to kind of do spirometry and look at and measure the effort of patients. But yeah, we've been extremely happy with this particular spirometer, and we've been involved with a lot of hospitals comparing clinic to home spirometry with it.
Are there any devices being evaluated for lung sound analysis?
There's some research done on that, but nothing on the market.
All right, next question for Richard Costello. Thank you for the wonderful presentation. I'd like to know what device or app you use to record the ICS LABA usage.
Yeah, that's a device that our research group developed. It allows a method of assessing the acoustics as well as the time of use. So it's somewhat unique. There are devices available commercially in the United States. For example, Propeller Health are a vendor for a device that gives you time of use. It's externally attached to the inhaler. This is a very exciting area. It's developing very fast, and there's a number of vendors moving in that will be providing similar types of products.
I've got time for just a couple more questions. This is for you, Daria. Which type of clinical grade spirometer did you use in the program?
It's what Eamon was just mentioning. So it's the spirometer that comes with the patientMpower. It's the near handheld spirometer that populates all these data. This little orange thing looks about this big.
All right, next question. Did the spirometer in use for the transplant program interface via Bluetooth, where the results transmitted to the EMR from the phone?
Yes and yes. A lot more success with Apple than some other cellular platform like Android, but yes, this is all via Bluetooth. It auto-populates, at least in our EMR, which is Epic.
All right, next question. How much is the charge per month for the service?
So it varies depending on the specific requirements, so happy to follow up with the person directly if they send us an email to info@patientMpower.com.
Do you get flow volume loop information on handheld spirometry and reliability of the data for the spirometry?
So we will have that very shortly. In terms of reliability, we've done a lot of studies comparing clinic to home spirometry, and we are looking at other techniques to give patients feedback in terms of the effort and see if there's any anomalies in terms of the particular spirometry blow.
Next question, what has your experience been with elderly and frail patients using monitoring technology?
So yeah, go ahead, Richard.
No, surprisingly, many of them are very good at this. They take the time, they think it through, and they're as diligent, or not more diligent than many younger people. So you can't really make an assessment on age. Clearly, people with cognitive impairment, that's a problem.
Yeah, and in our experience, it's less about the age and more about someone's aptitude and willingness to self-manage.
You recommend continuous cardiac monitoring systems for use in COVID-19 clinical trials.
Richard, do you want to take that one?
Well, I think that might be a little out of scope here of how we've been getting our experience in COVID. So I think I'd pass on that one.
All right, next question. Who sets the parameters? Is it a consultant?
For us, it's us. So for our program, the physicians set the parameters, and this is something that we monitor very closely. And as Eamon alluded to, we do set alerts, so we get prompted if something falls outside of the predefined range, rather.
All right, we'll take one more question. In your experience, how accurate are home spirometers used daily relative to in-office and calibration accuracy checked spirometers?
I think this is a fantastic question and something that we're actually hoping to publish soon. It correlates very, very closely. So for our lung transplant recipients, we're seeing really, really close readings. We do end up bringing them in occasionally to actually do spirometry in clinic, and we have never really seen a huge discrepancy ever out of the 77 people that we have transplanted here.
All right, we are unfortunately out of time. Any final remarks or comments from our speakers before we wrap up?
Thanks, everybody, for listening.
Absolutely, yes. Thank you.
All right. Again, thank you to our speakers. Thank you for joining us today as well. Industry Innovations webinars are archived on the ATS YouTube channel under the Industry Innovation playlist. This concludes today's program. Again, we thank you, and have a great rest of your day.